Welcome to Live from One Cancer Place. I'm Sarah Kelly. Today on Live, our own Dr. Chris Heery, Chief Medical Officer at Arcellx, is joined by Dr. Mark Lewis and one of OCP's favorite patients, Shauna Grewell. Dr. Lewis is the Director of Gastrointestinal Oncology at Intermountain Health. He serves on the Board of Directors of Neuroendocrine Tumor Research Foundation, as Vice President of American Multiple Endocrine Neoplasia Support, and as Chair of Digital Engagement for the SWOG Cancer Research Network. Dr. Lewis received his medical degree, completed his internal medicine residency, and served as Chief Resident at Baylor College of Medicine in Houston. After completing a hematology oncology fellowship at the Mayo Clinic in Rochester, Minnesota, where he served as chief fellow, he returned to Houston, where he worked at the University of Texas MD Anderson Cancer Center with a dual appointment in general and gastrointestinal medical oncology from 2012 to 2016. We are so glad to have you here today to join us. And I would like to thank our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics.
Steven, it's good to see you. You got your hand raised. What can we answer for you?
Yes, I put a thing in the chat there.
Yeah.
Just looking ahead. So ctDNA is sort of part of, the NGS family of things largely, and I'm particularly interested in what role that whole genome sequencing might have in helping predict or to provide more information about cancer risk, which would then lead to personalized aspects to prevention and surveillance. There's so many. I look at the number of gene mutations which are implicated in cancer pathways in colon
cancer,
and so often they're the same ones that are in say, breast cancer or something else.
Yes.
There's a lot of stuff there. My family, we're not Lynch, but we have a very strong thing to the point where one of my brothers, he died of it just 2 years after me. Just soon after I got it. Another brother, he's had early stage polyps removed. My aunt died of it. My grandmother had it when she died. Her sister had it. It's really very strong.
Right.
But it's not. But we aren't Lynch. So Lynch is a specific set of tests for specific ones. But I know from the work that I do that Lynch doesn't cover all the ones we know about, let alone the ones we don't know about.
Right, exactly. Well, let me just say, first of all, I'm sorry that you and your family have been through that, especially for the loss of your brother. That really is awful. And as Shauna can tell you, where we live, this is a state that is very family friendly. And in fact, about half the state can trace their genealogy back to about 8 settling families. So what that's done is it's amplified through founder effect certain polymorphisms that you're right would not normally be flagged as saying, okay, this is definitely going to give you colon cancer by the time you're 50, like we would see in, say, familial adenomatous polyposis. But I think what we're learning is the combination of the polymorphisms is actually probably where the risk comes from. So really the answer to your question is we are in our infancy here. And my own personal experience is if I had tested my own genome prior to 2007, the mutation that actually gave me my cancer would have been labeled as a variant of unknown significance. It was only by 2007 and thereafter that it became clearly pathogenic. So I think just the acknowledgement this is evolving. It very seldom, I think, comes down to just one gene. I think we're going to be increasingly looking at polygenic combinations. And I think we're probably going to need supercomputers to do that because there's no human being that can sit down and figure out all the permutations. The last thing I would say is I am very wary of a bell that you can't unring. So you and your family clearly have been afflicted. At the general population level, there are increasingly these tests. I don't know if they're being marketed in the UK. They certainly are marketed here in the US that are called, let me get this right, MDCT, MCDT, multi-cancer detection tests.
Mm.
And my problem with them, back to Chris's point earlier, is their statistical reliability. Like there's about a 50% chance that if they detect a cancer, that they'll be right in telling you where it is. So in my mind, telling someone that they might have pancreas cancer is psychologically very, very damaging in a manner that may not be reparable, even once you come back and say, oh, sorry, we were wrong, the test was flawed. So I think we have a long way to go in, to your point, whole genome surveys, certainly at a population level. I think family history still matters. And the last thing I would say is, just yesterday, I saw a patient, maybe not unlike your kindred, where they didn't have FAP, they didn't have Lynch, but they very, very clearly were developing polyps at a young age. So they had a polyposis syndrome that, to your point, did not fit some of our traditional sort of patterns. And so we've just decided to use their family as our rule of thumb. So we took the person who was diagnosed at the youngest age, took that age, subtracted 10 to 15 years, and we started screening their relatives then. So it's sort of a learn as you go type phenomenon. Mm-hmm. But I agree with you that we are incomplete in our genomic understanding, and we have to acknowledge the pitfalls of that.
Mm. And you must, it must be very interesting where you're practicing, in that you probably have a unique situation of being able to access hereditary information.
Yes, exactly right. That's exactly right. Exactly right.
Yeah. I just, to add, this isn't exactly the question you were asking, Stephen, but I think it's probably worth stating, is that whole genome sequencing, absent known risk factors, is really, really difficult to interpret, and in many cases is uninterpretable with the information we have. And I think there are two different ways to look at this, and you probably run into two very, very strong opinions on either end sometimes. One is we should sequence every patient's tumor at every time point with every sample we can get. There are people who believe that. Mm-hmm. And the reason that people believe, I want to just present both sides, because I can be convinced either way at times. And the reason people believe that is because they say, well, if we do this now, it'll give us a massive information that we can use either for this individual patient or for all patients collectively in the future. And if we don't start collecting it now, we'll never get to that endpoint. It's a very logical way of thinking about it. The other side is, well, I don't have anything I can do with it right now, so why would I put that cost on the healthcare system and on the patient? And sometimes even come up with a false diagnosis or lead them down a path of a therapy that might not be effective. And again, very logical, right? Like both of those things can be logical and make sense at the same time. And I just want to point out that if you are a patient who is capable of living with the uncertainty that those tests bring in, and capable of tracking that information for yourself over time, you should probably do it. Because then you can be your own advocate and you can help push along the science and you can find the right doctor and all of that. If you're a patient who's like, just tell me what to do, it's going to be really, really hard for you to help get all of that lined up, even to present it to people in the right fashion for them to use it. And now that, we're not really in the main part of the show, I'll just say I work with a group, particularly around one patient who's trying to found like a kind of a company, kind of an advocacy thing to do this for patients who really want to do everything for themselves and are willing to pay for it out of their own pocket. And even in that scenario, you almost have to write computer code just to aggregate all the information. It's just so much information. And just putting it in a format where you could communicate it to other doctors is really hard. So I would just say be careful what you wish for sometimes with that. Like make sure you're prepared for what you're going down, or with the path you're going down. But there are absolutely times when sequencing is necessary and should be done. And those times are in NCCN guidelines even now for most cancers. But I also just really empathize with you about there's something there and it hasn't been found. What I would also maybe suggest is try to find somebody who is a genetic counselor who is interested in doing this type of research, because your family may be a base case for identifying some polygene combination that results in risk. that would almost be impossible without your family's history. So you're already a great case to identify that. This is actually how familial pancreatic cancer was identified.
Yep.
Was, we just found patients who, like, everyone in their family seemed to get it. And then you go and you have to sequence all those patients. So if you're not already hooked up with somebody who's doing that, I would really encourage going to look for somebody. There must be someone in the UK, for instance, who is looking into that. And there are plenty of doctors who are looking for cases like yours to try to figure this stuff out.
Yeah. The other thing that then proposes really is that the need for this kind of health education at this kind of level for patients, patients who need to go looking at this thing. I get involved in a lot of different patient advocacy roles because I had a scientific background, and so I can understand it. But the average patient doesn't, so it's very difficult to self-advocate or to know where to look.
I actually, it's a real specific question, Dr. Lewis. Do you know anything about the Claude
trial
vaccine? Yeah.
Yeah. So
is that Claudin 18.2 or is it a different?
This is, I think, a different one, Chris. So if in a colon setting, I think this has to do with a microbiome derived vaccine that's combined with nivolumab in colon cancer. I think it's run by Dasari out of MD Anderson, who's a great colleague of mine. So Danielle, to your specific question, obviously it's a small study. We don't know the outcome yet. I will say that I think colon cancer and immunotherapy and how they are affected by the microbiome is probably the thing I'm most interested in this decade in GI malignancy. I think we're kidding ourselves if we pretend to understand that interplay. And I would actually say before Claude matures, we should be getting the results of the ATOMIC trial. So the ATOMIC trial, which you may have also heard about, just finished enrollment and is currently maturing. So it was looking at stage 3 colon cancer with evidence of likely efficacy for immunotherapy. And it was looking at traditional adjuvant chemotherapy plus adjuvant chemotherapy plus immunotherapy for those patients, specifically using the drug atezolizumab. So if that comes out positive, meaning that people with those characteristics benefit from immunotherapy in the adjuvant setting, I think it's going to be a total game changer as to how we approach some of these decisions in the stage 3 setting, and potentially has implications for stage 4. But Claude, I think, is in theory very interesting. And I think Dr. Dasari is a brilliant investigator, but I think it's so small. I don't know we'll be able to draw huge conclusions from it unless it leads to, say, a larger study. The Claudin 18.2 that Dr. Heery was referring to is a really interesting marker in upper GI cancer, where this is a protein that normally lives between the cells in what we call the tight junctions, and the cancer actually disrupts those, and then the protein pops to the surface and can be targeted with antibodies. So regardless of where you are in the gut, we are getting better at testing, but the most important part of the test is not just the result, it's what you do with it. And that's where I'm excited to see where we go with testing for immunotherapy candidacy and testing the microbiome. But how we do that reliably, I just don't know yet.
Thank you.
Yeah, you bet.
Yeah, I don't know, Danielle, if you've ever heard me, but my main area of research when I was still in practice was vaccines for cancer, and primarily for colorectal cancer and combinations. And I think just to highlight something for this group that Dr. Lewis was just talking about is we have not seen great success with checkpoint inhibition in late stage disease. And if we do see a differential impact in early stage disease where there's a small amount of tumor, what it would suggest is that as a tumor gets larger, it's harder and harder to treat with the immune response, which is fully supported by almost every preclinical model you've ever seen. It's even supported with really well-documented good immunotherapeutics in other cancers. And in particular, colon cancer has some things in the microenvironment that make it really hard for T cells to get in there and kill it. So there's a lot of scientific rationale for why this might be true. But I also want to point out that it's part of the reason why no matter how good a vaccine is or how good the target is in advanced colon cancer, that vaccine may fail just because of the way the tumor sort of lives. And that is a really hard thing, because what it means is if we have a perfect vaccine with a perfect target, we'd still have to go to newly diagnosed patients to see its best impact. And that is a trial that would take 5-6 years to read out at best and cost a lot of money. And I mean a lot. And so it's a really hard challenge that we haven't quite figured out how to navigate in this field. And it's part of the reason why I work on cell-based therapies for cancer now, because I figured if we can figure out how to remove some of the variables, we can come back to vaccines later. But just my own opinions, I don't want to discourage anyone from looking at any cancer vaccines. I'm obviously a big fan of the scientific merits, but it has proven to be a real challenge in the clinic.
Thank you for clarifying that.
Any other questions?
I would actually like to introduce Theresa had a question earlier. So that Theresa, go ahead.
Yeah, I didn't know if mine was too specific for the group, but since we're done with the talk, so I was on a trial, shouldn't have worked, and very also very patient-driven care because there were no answers and no trials when that happened. Anyway, I found a trial. To everybody's amazement, it worked. There are no papers written on it. Nobody talks about it. It's a difficult. I'm MSS, wild type, low tumor burden, and I've been off treatment and in remission for 18 months from pembrolizumab and pemetrexed. So, but I just had a CT scan and not a CT, my CT was clear. The MRI showed a possible lesion. I'm meeting with the doctor in about a half hour here to discuss what to do. This hospital had no real options for me when this started and wasn't real keen on me going somewhere else, but I did. I mean, I've gone through Sloan Kettering and MD Anderson and found the trial by myself because there just weren't any available. So the one thing that I was going to ask when, because I'm not sure if there would be a better way to look at this, is should I be getting a ctDNA?
I see. Well, first of all, Theresa, I wish you the best at your appointment. I'm sorry that that's hanging over you, and I'm particularly impressed that you participate today when you've got that on your calendar. So wishing you all the best. I would say that in the era, especially of radiology reports being immediately visible to patients, which I am in favor of, I have seen a lot of incidental findings, thankfully benign things get reported that ultimately are of no malignant significance. But I agree with you that if, let's say you go today and they say, well, we still don't quite know what it is. It's equivocal. It could be this, could be that. That actually is a setting where I think circulating tumor DNA has some utility, and I think it would be worth bringing that up. So I wish I could give you more reassurance at this moment, but that I think is probably how I would head into that visit.
Well, a ctDNA would tell me if my cancer has changed or morphed, or give more information as to what would be the best line of treatment if that in fact is this as a subcentimeter lesion possible. So
there's a couple different ways of doing it, and I know Dr. Heary was saying there's a whole other ctDNA talk, but really quickly, and Shauna even probably can speak to this better than I can, but there's tumor-informed ctDNA and there is tumor-uninformed. So without endorsing any brand names or specific tests, some of these tests require tissue from you to sort of make the bespoke, Theresa blood test, and then they are looking for your cancer, assuming that it hasn't changed its stripes. Most of these tests are looking at parts of the cancer genome that we would not expect to undergo evolution. Okay, so a fingerprint that would stay distinctive. There's other tests, however, that are really looking for methylation patterns that are not specific to your cancer, but would be seen in most colon cancer. So when you talk about circulating tumor DNA, it actually does matter which assay you're talking about and what tissue they have available or not to test. So it kind of depends what your doc would have to say about that. The last thing I would say is, and I have no idea where this spot is on MRI, sometimes the only way you get the answer, you probably know where I'm going, is biopsy. And just yesterday, in fact, I saw a patient who had a cancer in a really, really tricky spot between their aorta and their vena cava as those vessels descended in their abdomen. And we ended up actually relying on circulating tumor DNA to prove that, unfortunately, this was a recurrence, and now we're treating them accordingly. So I do wish you the best. I hope you get good news today. I know we all share that sentiment. And if there are any lingering questions about the meaning of the MRI, I think it's actually very reasonable for you to raise these new technologies. Last thing is, and I thought maybe this is where you were going, I'm going to put in the chat, my whole thing about you being on a clinical trial and then the results apparently not being published, I think that is a real shame because you participated. Clearly, you benefited to some degree. And I think it's important that we respect the social contract and report the results. Sometimes what happens is trials are presented at our conferences, but they don't go any farther, so they don't end up in the literature. And I think that's unfortunate because negative results matter if they detract from us studying a dead end. You know what I mean? Like if approach X is clearly not going to work, it doesn't make sense to keep investing all this money and patients' time and livelihood in it. We need to know that that was a negative result so we can switch track.
My point is they need to look further into people that are MSS.
Yeah. Preach.
Because it worked on me. 18 months is, I think, success, regardless of what today's scan tells me. So,
yes.
And that, I guess that's why I was asking the question, will Keytruda have changed the molecular makeup of?
Oh, I see your point. I would, just knowing nothing else about your case, I wouldn't have expected Keytruda to do that. There are certain drugs that we use, specifically the alkylating agents, that we expect to cause a lot of DNA damage and change it. But Keytruda would not be one of them. And last thing I'll say, the ASCO GI conference that we were just at. So, Shauna was there and Erica was there. There actually was some evidence about a 2-drug immunotherapy combination in MSS. But I agree with you. That is the code to crack. How do we bring successful immunotherapy to patients like you? That to me is absolutely where we need to go. The MSI high folks, I'm not saying it's any picnic, but they, after Keynote 177, are very clearly candidates for Keytruda. We're still trying to figure out how to offer that to all of our MSS patients. I'll put that in the chat as well.
Thanks.
I'm going to say something that is absolutely not intended to be medical advice, but it's something just to consider. And it's a little far out there, so I just want to be careful with how I say it because I think it's something to ask your doctor about. But somebody who has had a truly remarkable response to immunotherapy actually falls into a kind of a different category than someone who has not. And if you had no evidence of disease for a long period of time and then one new site, there is no evidence to do what I'm about to say, meaning on large scale, but because it's so uncommon. But there is evidence that when someone has a great response to a therapy for lots of other sites of disease, and then one site comes back, that removing that site could ultimately remove the last clonal population of cancer cells. And so again, I'm not suggesting that you should, but I am saying if you needed to get a biopsy anyway, maybe the best way to get that biopsy would be something that takes the whole thing out. And then maybe you get 2 advantages out of it. But it depends on where it is. It depends on a lot of different things. And I just want to point out that this whole topic, we were just talking about Shauna's case where oligometastatic disease didn't used to be resected. But, this was a series that was published when I was still at NCI by some colleagues of mine who work in lung cancer. They were trying to find out resistance mechanisms to a drug called EGFR inhibitors in lung cancer. And so what they were doing was when a patient's tumor would shrink down to only like one site of disease and it wasn't gone, they would cut that thing out so that they could look for the resistance mechanisms. And lo and behold, out of the 10 patients they did that in, 2 of them never had their cancer come back at all. So they said, oh, maybe we just learned something, right? Maybe we just learned that the drug actually eliminated everything it could and left behind just this tiny fragment of cells. And by cutting it out, we just kind of solved the problem by accident, right? And again, I'm not suggesting that that is what would happen for you. But what I am saying is it's worth the discussion to find out, because if it's in a safe place to cut it out and it gets you access to the tumor tissue and you could use it for these other tests that we're talking about, maybe it solves a few problems at once and just something to think about, right? And please don't take that as like I'm telling you to do it.
No, it was on the top of my brain. Well, maybe they could biopsy it and take the whole stupid thing out. But
well, in 20 years from now, we might look back and say, why weren't we removing the one thing that came back? I mean, we just don't know how it'll play out, and it might be different in different diseases. And so we have no idea in your case whether that's right and whether it's safe and all that. But these paradigms are going to shift at some point.
Awesome. Well, thank you for your feedback. I really appreciate the time you guys spent with me.
Good luck, Theresa.
Really awesome talking about all of the advocating and how doctors really need to tell patients to get out there and connect with each other, because that's how the information gets shared quickly and you find answers. I wouldn't be here if I didn't. So.
Well, thank you for being a self-advocate. Thank you for leading the charge for MSS, and just wish you the best of health.
Thank you.
Yeah.
You too.
And Steve Holmes, I see your comment here about your case. That is, I would say unbelievable, but I personally treated a patient with an anti-PD-L1 who had a bile duct cancer and had an amazing response also. So it's not unbelievable, but it's fantastic that happened. That is such a great story. And did you end up having anything resected after the response, or was it just?
So I had the Whipple.
Okay.
Followed by an aneurysm.
Oh, sorry, I missed that.
So no, that's all right. I didn't put the yes, the Whipple's in there. My brother also had that. My younger brother. He didn't have any of the advocacy or support that I had, or that I ended up getting. He died. Exact same diagnosis. So to Steven, I was tested for Lynch and didn't have it either. So two brothers, essentially 2 years apart, same exact diagnosis. And my brother was in a different area of the world and had no support. The doctors didn't know anything about cholangiocarcinoma, and in his case, he passed fairly quickly. I came along and I had exposure to different mindsets, different oncologists who had more searching view. I had zero, as I put in my little comment there. I didn't have any options left. They had to put a pen in my hand and move my hand to sign the document for that contract. That's how weak I was. And really, I just stay alive for 30 days. That was where I was at. And it turned me in 3 days. So unofficially 3 days. I know that what happened. And then it took 9 weeks to measure it. I went from not being able to do anything to literally walking and thinking about running, because I had a passion for that sort of stuff. So that was me. And so obviously that's why I'm here. I'm doing my bit now to help people understand what's possible.
That is amazing.
That is incredible. And Steve, I've had a Whipple too, but I'm not on my bike for 3 hours a day. So
my oncologist was a passionate cyclist, and look, we connected because of that. He loves cycling, and I came along and I love cycling. And my daughter, who attended the meeting at that time, just thought, this is nuts. What are they talking about cycling for? And so that just went on to become a connection that helped me survive. And he thought about what he could do for me. And Keynote 158 wasn't available at that stage for me. And I became that first intake of 9 in Keynote 158. So my figures are easy to follow. I'm that one outlier that you'll find.
Well, you know what I'm reminded of there, and I know we need to close, Chris, is that there's this quote from Arthur C. Clarke that any sufficiently advanced technology is indistinguishable from magic. And I think what you're describing, whether it's your response in Keynote 158 or what I said earlier with my dad and the very, very early days of growth factor, like if you've never seen it before, it is so striking when patients improve like that, whether it's you or my dad. And again, as you know, supposedly rational scientists, like we start to sort of realize that this is something beyond our understanding, and it attracts us. We then seek, sort of the explanations for it. But it is absolutely amazing, and you are clearly thriving. And thank you so much for joining. It's an incredible story.
Yeah,
I think
absolutely. Oh, sorry. Go ahead, Sarah.
Sorry, I was just going to say, he questioned earlier how much that you think the patient literacy and education has to do with improved outcomes. And I think that's a perfect example. That's
totally agree. And I know we need to close here, but I would say that, the last couple of years have been instructive about where we are in terms of health literacy. This is obviously a hyper literate audience, but, I think we're told that in communicating with the public, and I'll use the US educational system here to sort of kind of aim our messaging at like the 7th or 8th grade level. I have a middle schooler at home, so I often think, okay, how would I explain this to him? And that's challenging. It's challenging enough to understand cancer. It's then even more hard, I think, when we put the onus of responsibility on the patients to like figure this all out themselves. So I think groups like yours patients helping patients and advocates helping patients to become their own advocates, I think that is the solution. I'll be very honest, oncologists, we can't do it by ourselves. And in fact, you have a level of trust among your kin, so to speak, that's very, very difficult for us to replicate.
Yeah, so true. And we're really, I think we're really lucky to have the group that Erica has helped to pull together. And I think as this group keeps growing, it'll be easier for people to talk with each other about what are the questions they understand and don't understand. So it's really going to be a self-fulfilling prophecy eventually that this group will sort of sustain itself with the help of experts like Dr. Lewis to give extra insights. So I know we're out of time, and I actually have to get to a meeting myself. So I want to thank you again, Mark. It really was super fun for me. So I appreciate the time.
Absolutely. Loved this, Chris. Loved this group and talking to you all. And I wish everybody the very best of health.
Thank you. So I would like to thank you all, to our viewers who joined us today, and a special thanks to our experts, Dr. Chris Heery and Dr. Mark Lewis. And once again, I'd like to thank our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. And we look forward to seeing everyone next time on Live at One Cancer Place.